and a very warm welcome to today's Cell and Gene Therapy Insights webinar, titled Automated and Streamlined Manufacturing of TIL Therapies. I'm Lauren Coyle, an editor at BioInsights, and joining me today are Ian Hardy and Lars Nye, who will explore a novel automated TIL manufacturing process to streamline production for clinical applications, with insights from Dr. Ian Hardy on how process efficiency and Dr. Lars Nye on using TILs for treating liver metastases and for ocular melanoma. Now, I'd like to introduce our presenters. Ian Hardy, Director of T-cell therapy at Miltenyi Biotec, leads efforts to develop innovative T-cell therapies, including launching the Clinimax TRT Prodigy process from concept to clinical translation. Lars Nye, a professor and oncology consultant, leads melanoma research and cell therapy trials, with over 100 publications and more than 20 clinical trials coordinated. So without further ado, I'll hand off to Ian to kick us off with the first presentation.
Good afternoon. My name is Ian Hardy. I'm a manager of personalized medicine at Miltenyi Biotec, and today I'll talk to you about automating and streamlining the manufacturing of TIL therapies. Tumor-infiltrating lymphocyte therapy is a method of where we are able to derive reactive T cells from the tumor of patients. This results in a cell product that is polyclonal and diverse, allowing us to target the tumor through multiple TCRs. It's associated with low toxicity and has been in the field for quite a while and has long-standing evidence of efficacy in solid tumors such as melanoma and lung. Unfortunately, there's high product variability. Part of this is inherent to the nature of the product, which is derived from a tumor material. And part of this is due to non-standardized manufacturing, which results in a product that often is variable between labs, between groups, and between patients. But there's been much progress in recent times, including the first approval TIL-based drug in February of 2024 by Iovance, which has helped fuel the excitement for this type of therapy. A recent study from John Hannon's group at the NKI has shown the benefit of TIL therapy versus ipilimumab in a phase 3 trial where patients were randomized with advanced melanoma. Shown here, you could see an increase in progression-free survival as well as durable control and perhaps cures for a portion of the patients that were under treatment. Although there are many challenges with TIL manufacturing and the translation of TIL to a therapeutic drug, current methodologies that exist are laborious and time-consuming with many open steps. This requires a lot of expertise by the people performing the procedure, and also a long time of production that can be between 35 or longer days. This requires many open steps, which can be prone to contamination, requires a lot of clean room time and staff, as well as lots of multiple ability to quality control the product throughout the time, and disconnecting the data flow and recording of the process because it's not automated. At Miltenyi, we have a lot of experience in automating cell therapy, including engineered T cells, engineered HSCs, and others. And I'll talk to you today about the work we've done at Miltenyi to automate the ability to make TILs on the Clinimax Prodigy platform. The Clinimax Prodigy TRT process enables GMP TIL manufacturing. I'll show you first the ability to expand outgrown young TIL. We have a process that automates entirely within the Prodigy the addition of feeders, T cell activation, optional transduction, expansion, and in the future for harvest. This process is supported by other parts of Miltenyi, where we provide GMP reagents for much of this process, including anti-C3, Tex-Max medium, cytokines, and tubing sets. We also have a robust IPC-QC panel that has been validated on other T-cell products that are available for use for the TRT process. In work in our group and we've done at Miltenyi, we've been able to expand and test the TRT process on a variety of tumor types, demonstrating high expansion and viability in this automated process that we've developed. On the left, you can see examples of melanoma young TIL that have been entered in the Prodigy process and automated expansion over the course of 2 weeks, showing robust expansion and viability at the end of the process. We further characterize other types of tumors in this process, such as here shown renal cell carcinoma, pancreatic, colorectal, and breast cancer, and TILs from those tumors show similar expansions, reaching numbers around 1 to 5 E9, all automated on the Prodigy. Although, of course, for many TIL applications, larger numbers are necessary and required. So what we've done is taken some work that was done by collaborators within Miltenyi who have developed a larger scale culture chamber for the use of CAR T to produce higher numbers of T cells at the end of that process. We've adapted this methodology for our own process and are currently working to release this to the market. But we are able in our own research to demonstrate the increased yield from around 5E9 in their standard culture chamber to up to 1 to 2E10 in this larger chamber. And we think as TIL products increase efficacy and are genetically modified, the numbers that are needed for patient treatment will drop to allow this to be the majority of patients being treated with these sorts of cell numbers. To walk you through an example of what the project can do in this process, I'll show you how we are able to expand and select tumor-reactive melanoma TILs, all automated, all in the Prodigy, as a potential case that could be used in the clinic. So this is a melanoma tumor digest where we allow the digest to sit for 24 hours, allowing the T cells within the digest to reawaken and activate against the tumor cells that are present. This upregulates the marker for activation called CD137, which we can then select in the Prodigy. Here's an example of what this looks like. On the left, you see the expression of CD137 after the tumor incubation that occurs in the Prodigy of about 20% reactivity. And after selection, we see expression about 95% of the T cells expressing the marker CD137. This is all automated and all GMP. We then entered both the positive and negative fraction into a rep expansion, again, part of the process, and are able to add feeder cells, induce activation, expand and harvest those cells, and then perform a 24-hour co-culture. And what we can see is that those TILs that were enriched for CD137 prior to the initiation of the rep, and which were used to seed the rep, have increased reactivity when co-cultured with tumor, upregulating CD137 to about 51%, whereas those TILs, which were depleted for the marker of activation, CD137, only had about a 3% reactivity. And while we didn't do the bulk that was previous, you can see that before selection, about 20% of the T cells were reactive, suggesting that we've increased the reactivity quite significantly by this selection. I also want to show you the use of work that we've done internally to push this forward. As an additional use case, we have also pushed the automation, selection, and expansion on GBM TIL. Using this process, GBM is not a traditional TIL tumor, thought to be cold, but we have done some work here showing the ability of this process to be able to robustly and repeatedly generate clinically relevant numbers of TILs from this indication. What we do is we take glioblastoma tumor digest, allow this to sit for 24 hours, just like the melanoma methodology, and then enrich for CD137 upon the end of the 24 hours. This allows us to enrich T cells up to about 90% or higher of CD137 that can be entered into the rep. Again, this is all automated and closed system within the Prodigy. The rep is then seeded, and we can see a robust and viable expansion of these GBM TILs, which reach a viable final product. And the amount of starting material we can begin with is even down to as low as about 2E4 cells that can expand quite robustly. We also then look at these cells after harvest, and you can see that the Prodigy has quite a high amount of TCM cells versus TEM, which is quite rare among TIL products. We think perhaps because of the unique features of the Prodigy, which is a similar thing that we've seen in the Prodigy when comparing the CAR T platform to other platforms as well. We also see TILs that are relatively not exhausted with this process. Further, we were able to take this process and culture it with autologous tumor lines and demonstrate that the cells that were enriched for CD137 targeting GBM were able to kill and exert more tumoricidal activity against an autologous tumor line than those TRTs that were not enriched and expanded on the Prodigy, or those for which the markers CD137 were depleted. This demonstrates both the benefit of the enrichment of the TILs prior to the start of the rep and to facilitate higher reactivity of the end product, but also the necessity of doing this because when we deplete the product, we get a worse reactivity. And so therefore, we've been able to develop a manufacturing platform for glioblastoma TIL using the TRT process, resulting in a 16-day manufacturing time, allows us to bypass the pre-rep phase entirely by the use of the digest and the selection methodology. And this direct selection out of the tumor digest is automated as well as an automated expansion. And we have built an IPC-QC that we've mostly borrowed from the CAR-T field to allow QC steps during the course of the manufacturing process. So in summary, TIL therapy is a highly promising modality for the treatment of solid tumors due to its polyclonal and individualized nature as a drug and its high safety profile. We developed an automated, fast, and flexible clinical-grade TIL manufacturing using the TRT platform that's feasible and results in robust numbers for multiple indications. Miltenyi provides solutions for many next-generation TIL manufacturing concepts, including multi-parametric TIL sorting, genetic engineering, which I didn't describe today, but are things that we are releasing now or soon and are working on. And also with this automated TIL manufacturing process is supported by QC strategies, protocols, and documentation certified that's available from Miltenyi. And lastly, we've demonstrated a use case automating the expansion of glioblastoma TIL for the manufacturing and resulting in a 16-day enriched cell product that has enhanced tumor activity. And so I'd be welcome to take your questions after Lars talks. And now I'll pass over to Lars for his presentation. Thank you.
So thanks a lot, Ian. I would like to try to share our experience using this approach in our ongoing clinical trial. And the title for my talk here will be Development of Local Regional Cell Therapy in Patients with Liver Mets of Ocular Melanoma. So the interest of tumor-infiltrating lymphocytes, as you heard, is increasing in a number of different tumor areas. And we should remember that these cells actually are quite a variety of cells, and they typically are lymphocytes left the circulation and located in the tumor. So there are a number of cells that are present in this, and the heterogeneity in between patients could be quite extensive, actually. So where we come from is quite a rare disease named uveal melanoma. That's typically a very small fraction of all melanomas, around 2%. In Sweden, we have around 100 new cases annually, and typically we have a very effective treatment for the primary tumor, but unfortunately 50% of the patients will develop metastatic disease, and that's where this disease will be very challenging. And what you see is the typical pattern in these patients with the number of liver mets in the liver. And today we have recently introduced a new therapy for a proportion of these patients with a drug called tebentafusp. Until now, we have also tried to use ipilimumab and nivolumab in combination, and we have also evaluated local regional treatment. And this we have done ourselves at our institute in a number of clinical trials where we have identified very interesting targets and some proportion of patients that have a very effective treatment for a shorter period. But as stated in the bottom of this slide, it's really a limited improvement in overall survival for the majority of patients. And that has led us to what you have heard already, to look into TIL therapy in melanoma. And the experience from TIL therapy is very much coming from Steve Rosenberg in his lab in the US, beginning in the late 80s. And recently we had this publication from the Danish and Dutch colleagues published in New England, where you have the graph that we just saw with a fantastic response, durable such, for a long period following this one-time treatment. And this year we also had a commercial alternative introduced for patients with the cutaneous melanoma by the introduction of lifileucel. So our own interest in TILs in uveal melanoma comes from work that have been carried out in the lab for a number of years now, characterizing these cells in both in vitro and in vivo experiments, and also in morphological experiments. That's what you see here on the left, really demonstrating that these cells have the potential to be extremely effective in diminishing and taking away the tumor burden in these animals. And that corresponds also to findings from Rosenberg's lab and co-workers, where they actually done a phase 2 clinical trial, and that's what you see to the right. And in this trial, it's demonstrated that both treatment-naive and previously treated patients, to some extent, have interesting and promising clinical efficacy. And this observation led us to take our own observations in the lab to design a clinical trial with a slightly different approach than what has been tried in the past. And that's where we have introduced the Prodigy from Miltenyi with this automatic manufacturing of these cells, but also adding a new component in TIL therapy by administering these cells directly into liver circulation by local regional administration in the hepatic artery circulation. So the objective of this phase 1 trial, the first in a number of planned studies, is to determine the safety and feasibility and explore also a number of factors influencing the effects in man in patients with predominantly disease engaging the liver. So the specific aims involve to see the feasibility and in number of factors corresponding to the manufacturing in the bioreactor system of Prodigy, and if we can see that we fulfill the criteria that is required from regulatory requirements. Secondly, to see if it's feasible in a clinical context, administering the cells directly in the liver circulation without any safety issues. And then also look into in more detail how we could potentially influence and analyze both the preconditioning therapy with chemotherapy, and that in our case is melphalan. That's quite unorthodox. In other trials, other regimens have been tried more extensively. And we have also an interest in also influencing the IL-2 treatment, where different regimens have been tried in the past, both high dose and low dose. And of course, this relates also to investigations of biomarkers and factors influencing the immune-mediated effects. So in short, we have done a lot of laboratory work of validation the product, and also the manufacturing process, comparing what we do typically manually with the automated production and manufacturing. And we have done that in both in vitro and vivo, and shortly you can say that there is no major difference in this. We have the same product as we view it with the automated system and the manual production. And we fulfill the criteria from the validation as required by regulatory agencies, including sterility, potency, purity, and identity criteria. So in our world, the process looks like summarized in this slide, where we have a surgeon taking a surgical biopsy. It could also be a biopsy taken by a radiologist, a core biopsy, that is transferred to the lab, where we isolate the TILs and from the liver metastasis. And after this first 2 weeks of cell culture, we have the TILs isolated, and then we take them further into the Clinimax project with an additional 2 to 3 weeks of manufacturing until we have a final product that is used in the patients and administered through the hepatic arterial infusion process. And this is what it looks like in a few photos: the handling of the tumor biopsy, and the preparation of the TILs in what we refer to the young TILs phase of the production, until we have the closed manufacturing in the prodigy. And this is what it looks like in the microscope with the intermediate product to the left, and to the right you see the final product that we use for administration in the patients. In this slide you see the operating theater with the interventional radiologists with the patient in the room. We have conducted this intervention both in full anesthesia but also in sedated patients, and it seems to work very well also in patients with only sedation. And you infuse the catheter in the femoral artery, and you reach the liver circulation, as you see in the left, where you have the catheter coming up and it's infused with in the circulation with contrast. And you see the diffuse black thing in the middle of the photo. That's the metastasis, and then you infuse the cells. And you can do that in many parts of the liver, depending on the burden of the metastasis in the individual patient. So the design of this trial is really much to have an understanding of how we could do this procedure the best, and considering that this condition is a quite rare disease. It's a quite small phase 1 trial with only 6 patients, with the dose escalation from 10 times 8 to 10 times 9 patients, with 2 patients on every dose level, using the melphalan as a preconditioning for lymphodepletion, and the low dose of IL-2 for 7 to 14 days after the infusion of the cells. And we include both patients that are treatment naive and previously treated. But important is that we only collect TILs from liver metastasis, and they should have a dominant liver disease to be available or eligible for this trial. And the primary objective is, as you have heard, safety and feasibility, with efficacy endpoints as secondaries. And to the right, you see the typical time frame for taking the patient from harvesting the TILs in metastasis until you infuse the cells, the post-treatment with IL-2, and the evaluation 6 weeks after infusion with the PET-CT. So the trial was approved by the authorities in January 2023, and we have now recruited 8 patients in the trial. We have had 2 screen failures, and that was related to one patient that had an additional diagnosis of another tumor, and the other one was a patient that we actually didn't reach the number of cells that was required to have a manufacturing. So we have now treated 5 patients, and one is patient is now in manufacturing process, where we will have the results and treatment in the next coming weeks. And to the right, you see patient number 2 with vitiligo, a reaction that we consider to be related to immune activation, and that we have seen in 2 patients. And in the bottom, you see the first patient that was receiving this treatment together with us in the study team. Evaluation of efficacy is something that is, of course, critical. And according to the study plan at present, we do, as in more or less all solid tumor studies, evaluation with RECIST 1.1 criteria. And in our case, we have that combined with a PET scan. And we have seen that in some patients, we actually have a decreased metabolic activity in the liver, but it's not fully captured by the RECIST evaluation. So there is a lot of things to do with the evaluating TIL therapy in this group of patients. So by this, I would say that this study very much illustrates academic work, taking experience from the lab to the patients, and where we are now is, of course, to evaluating the results we have received and taking that back to the lab in order to have another phase 2 or phase 1 trial with some changes made. So to conclude, I would say that already at this stage, where we know almost have a fulfilled phase 1 trial executed, and the ClinicMax Prodigy is capable for delivering a drug product that fulfills regulatory requirements for human use. We have also had a very interesting experience with hepatic artery infusion, and find that that is both feasible and safe, considering that there was some concerns regarding both thrombosis and bleeding with this procedure, but we have not seen anything like this in our patients. Where we have an anti-tumoral activity, and that also is corresponding to shrinkage of tumor. It's too early to say anything about this at this stage, but clearly this is promising. And I would say that the dosing of the TILs, as you heard by Ian, is something that could be of very large interest for the future, where we have the potential to increase the dosing. In addition to this, the IL-2 is something that is very challenging, and we're also addressing this factor in future studies. So today we have a number of outstanding questions that, of course, is already captured in the presentations from me and Ian today. And then that is related to, should we go for bulky TILs, or should there be a selection of TILs? And what can we do with preconditioning in IL-2? Is there something to do with the patient selection? What can we do to not missing important efficacy evaluation in relation to imaging? And what will the biomarkers bring for clarification of how this works? So by this, I would like to thank all participating colleagues, and of course, especially the patients and their families. Thank you for listening.
So all that's left is to thank Lars and Ian once more for a great presentation, and thank you to you, our audience, for listening. We hope you'll join us again soon.